Hi, my name's David Weinerman. I want to thank everybody here, Judy and Julie, and whoever else I don't know who involved in arranging things today, for inviting me. It's nice to be here with you. I've been working in care for patients at the ACMC GI division since May. A little bit about myself. I'm from Columbus, Ohio, not too far away. I grew up there, did training in Ohio State for medical school, and in Cleveland at Metro Health for internal medicine, and in New York I did a fellowship in gastroenterology and liver disease. And I spent 4 or 5 years working in the Cleveland area until I found out about ACMC, and happy to have been here since May and really enjoying working with everybody here and for meeting and caring for so many nice people. And I'm married with 5 kids aged almost 4 to about just turned 13, mostly girls, besides for one son. Everyone asks me how the drive is here, especially in the winter time, and it, so far so good. It has been not bad at all. And the roads are great, and the weather hasn't been too bad. So let's hope for another good winter next year. I don't know how many people here came to actually hear me talk or came for the dancing and the points. But how many people here have any interest in learning about colon health or colonoscopies or colon cancer or anything like that? Anybody here have particular interest they want to talk about afterwards? Anything that burning GI topics? Okay, so we'll get to those after the quick talk here. So first off, so colon health and digestion are very linked. Digestion does start with the mouth and continues all the way through, at least to the small intestine, if not some in the colon too. We'll focus on colon health, but certainly anything else is fair game too. So first, a list of some facts that are relevant. Colon cancer is the second most common cause of cancer deaths, and this is about 8% or so of all cancer deaths. I believe other common cancers are breast cancer is very common, lung cancer, prostate cancer. So the lifetime incidence for colon cancer on the average risk Americans is a little about 4.5%. So for men, it's about a 1 in 22 risk of getting colon cancer during a lifetime, and for women a little lower at 1 in 24. Breast cancer is the most common in men and women, and prostate in men. Breast cancer is 1 in 8 incidence. So clearly this is not as high a burden as that, but this is a more still very high incidence cancer. Most, about 90%, occur after the age 50, but clearly some occur before age 50, and that number has been increasing as well. About 1/3 of patients who are diagnosed with colon cancer will succumb to that disease. What that means is, though, that others are able to survive after it's made, and they end up passing from something else down the road. And very importantly, that this is a cancer that is probably pretty much preventable. And we know that screening for colon cancer does save lives. In fact, since 2004 until 2013, and this still is continuing since then, deaths from colon cancer have decreased an average of 2.7% yearly. And some estimates say that even more than half of that is due to colon cancer screening. There may be other factors as well in terms of other impacts on colon cancer. So here's a slide from Up to Date, which is a medical site that shows someone here with a baseline average risk of 1 for developing colon cancer, and how that risk is affected by having relatives who've had colon cancer. So genetics are probably the biggest risk factor for colon cancer, among other ones as well, which we'll get to after this. But in terms of genetics, it's important to note that 70% of people who are diagnosed with colon cancer have no known relatives who have colon cancer. So that's the high majority of patients do not have someone who has colon cancer. But if you do have a known relative with colon cancer, the risks are increased even more so. So here you can see over a twofold increase in risk if there's one relative who had colon cancer. So if someone's mom had colon cancer at 70, or their father, or a sister, or brother, then their risk is doubled. So from 1 in 22 to 1 in 12 or 1 in 10, etc. If the relative who had colon cancer was diagnosed at less than age 45, the risk goes up to almost fourfold. And if there were more than one relative with colon cancer, it's even higher. So you can see the genetic component to this disease. Other factors that also have some effect, although not to the same degree, include lack of physical activity, daily consumption of red meats, specifically processed meats. Someone's having daily lunch meat every day. That's what this data showed. And this is not as high a risk as genetics, probably like 25% increased risk, for example. Obesity is also a big factor. Not on here, but diabetes is also a big factor. About a 38% increased risk for colon cancer diabetes. Smoking causes an increase in hyperplastic polyps, which can be a cause for colon cancer. And then, alcohol use, not just a glass of wine daily, but a few drinks at least every day. And then the biggest decrease probably is from consumption of fruits and vegetables and fiber, and less benefit, but some maybe, from some other vitamins and medications like aspirin and calcium, etc. So most, if not all colon cancers begin as polyps. Polyps are like little moles you could picture on the skin, but inside the colon, and they're not normal. We don't know how many of these polyps go on to cancer, but all cancers pretty much begin as polyps. So here's a picture of a diagram of how a polyp can be removed and prevent cancer. So here you see a small colonoscope. It's about that size, inserted through the rectum into the colon, and your whole colon is examined. And here you can see a stalk with a polyp on it, and there may or may not be any cancer in that polyp. And here, as you can see, the snare passing through the channel on the scope, and it's around the base of this polyp. And then with or without cautery, the polyp is removed, the polyp is retrieved with suction, and sent off to the lab to be examined for any signs of problems. So that seems very straightforward. So why don't we have more colonoscopies? Here's a picture of that from an actual polyp, of a small polyp being removed. So what's the obstacle to colonoscopy? Well, one is getting patients to show up for their appointments and get them done. He can't tell if he should go into the colonoscopy or the IRS, so clearly he's not very motivated. Getting screening done is the first step. So because of that, I think most people would agree that for most patients, a colonoscopy is the best way to screen. But if you're not going to do a colonoscopy, what's the next best thing? Because we know that there are a lot of patients today who could have a colonoscopy, they could afford it, insurance covers it, and they still don't do it because of fears or whatever it is. So these tests are done. Their main role is to increase the number of patients who are getting screened, with the idea that if something is found abnormal, they would then go on to a colonoscopy. Because doing a stool test and finding something wrong and then ignoring it doesn't help anything. But these include looking for occult blood in the stools, a similar test called a FIT test, which you may have heard about. It is a little better accuracy than just a regular occult blood. It doesn't require the same kind of dietary avoidance beforehand. The newer test called a Cologuard has been approved by the FDA. Combines the FIT test and DNA markers. And it's important to recognize that these are not perfect tests. This is the best test we have so far. It still misses 8% of cancers and has many false positives too. So it's the best of these, but still not perfect. Not as sensitive as a colonoscopy would be. Other things that you may have heard about are virtual colonoscopy called a CT colonography. That's an X-ray test by radiology. You still have to drink a bowel prep to clean out the colon, and it's good at finding large polyps, not as good at finding small polyps. Also not good at finding flat polyps. And flat polyps, we think are probably a large part of missed colon cancers. Large polyps turn to colon cancers, so called interval colon cancers. And if you have an abnormal result, that requires a colonoscopy afterwards with another bowel prep, etc. Capsule study is also available, which is a little camera that's swallowed to look at the colon after a bowel prep again, and again, it requires a bowel prep twice if you find something wrong. So these are really not as useful for the average person. And then sigmoidoscopy, something that's been done in the past to look for colon polyps. But the problem with that is well, the advantages to that is that you can do it without any sedation. It can be done. It's available. Some internists have been trained to do it too. But you can see a sigmoidoscopy only looks at the left side of the colon, so it stops roughly around here. So there's a whole another half. It's like getting it's like getting one breast mammogram. You know, it's good for that breast. How about the rest of the body? Right. So here you see a diagram of the different channels: a light channel, and a video camera, and a suction or air catheter channel. And this is an example of a colon that was located right here, a colon cancer. This is the cancer over here. So clearly, if you only did a sigmoidoscopy, you would not be finding this cancer over here. Besides just screening, obviously, if someone has warning symptoms, such as rectal bleeding, change in bowel habits, unexplained iron deficiency anemia, or unexplained abdominal pain, those are the things you want to get seen soon to get checked on. So what's the biggest obstacle to a colonoscopy in terms of patient concerns? I think most people would say it's the prep. That's probably the procedure itself. You're lying on your side, you're napping, under some medication, not usually a big concern for patients. But it's the drink, it's the amount you have to drink, it's not the best tasting in the world, and it causes diarrhea. So there are newer preps. There are a number of varieties of medications that have been made to try to address these issues. They all still cause diarrhea. You can't get around that. But there are some that are better tasting, smaller volume, so that does help things. For example, Movi Prep, ClenPick is a new one, a number of different options that make that easier. If anybody wants to know about probiotics, there are some data on probiotics in Digestive Health, best studied in patients who have inflammation of the colon called inflammatory bowel disease, like ulcerative colitis, who have had surgery on their colon. There may be some role for helping out with duration of diarrhea from infections, or decreasing the amount of diarrhea with infections, and less so for just abdominal constipation, diarrhea, bloating. Although some patients do say it does help, it's not been able to be studied as well to prove it. So that was the slides that I put together, and as you know, we're right across the street, a stone's throw from here, at the 2112 Lake Avenue. The staff there include Tammy, Tracy, Heather, and Doreen. I am there along with Dr. David Novak and our wonderful nurse practitioner, Jerry Berg. And then I can't not mention our wonderful nursing staff over on the 4th floor at ACMC. Too many of them to single out, but they're all excellent. So, can I ask any questions about this talk or other topics you wanted to address while I'm here? Gentleman back there, raise his hand.
I turned 50 this year, so I think I'm going to be due for my first colonoscopy. No applause, please. I'm just curious, when you do a colonoscopy, do you do the large and small intestine? Do you inspect it? Because I'm just picturing if the small intestine's 20 feet long and the large intestine's 5 feet long, all I can picture is 25 feet of hose.
That would be challenging. Yeah, no, the colonoscope is about 4 to 5 feet long, 160 centimeters, so it's 30, yeah, so like 4 or 5 feet. And it does not look at the whole small intestine. The goal is to look at the whole large intestine, which is the colon here. So from the rectum down the top of the colon. The small bowel begins here, and oftentimes it is possible to see the very end of the small bowel, although that's not really necessarily part of a colonoscopy. So, I didn't go into the guidelines for when to do it, but you're right. Starting at 50 for average risk people. Earlier, if someone has a family history of colon cancer. If someone had colon cancer at 55, then the relatives just should start 10 years earlier at 45.
Also, if they didn't have one until they were 80, I'm safe until 70?
Well, no, because some would start even at 40 in that case. 10 years earlier, and then if it's normal at 40, then you do it at 50, then at 60. So typically, if you had normal colonoscopy, the repeat would be in 10 years if there's no family history of colon cancer. If someone had colon cancer at a young age, the relative had colon cancer at 55, then it's recommended to do every 5-year checkup colonoscopy. If someone had polyps removed, then that also changes the interval for the next colonoscopy. It could be 5 years later or 3 years later, and then if they're normal, that might widen again to 10 years eventually as well. So that depends upon the results of the follow-up colonoscopy. She had a question, I think, too.
Mm-hmm.
Yes?
I trust that you know what cholangitis is.
I do.
And just off the top of your head, what would be the single best thing that someone could do to prevent bouts of cholangitis?
So cholangitis, by definition, is inflammation of the bile ducts. So this is the ducts that drain the liver and bile, and can't include the gallbladder if it's still there, and that drains out into the intestines. And the inflammation there can be due to various things, depends upon the circumstances. Sometimes it's due to narrowed areas in the bile ducts or due to stones that can come from the gallbladder into the bile ducts. And sometimes you can get cholangitis after having a treatment for stones called an ERCP, where you can get bacteria contents and debris that backflow into the bile ducts. So it really depends on the details of the situation as to how to treat it. That can be dietary interventions to low-dose antibiotics periodically, to occasional just procedures to clean out the bile ducts sometimes. Hard to give one answer for everything.
You're gastroenterology, right?
Yes.
My mother has Barrett's esophagus. Am I at increased risk? And if so, what can I do to diminish the risk?
Barrett's is primarily caused by acid reflux. So acid belongs in the stomach, that's where it's meant to be, it has a purpose there. But if acid refluxes up into the esophagus adapts to try to respond to that high acid state, which is not really meant for. And that in the process of adapting to the acid, the esophagus lining becomes more similar to the stomach lining. And that change makes the lining there at risk for becoming precancerous, called Barrett's esophagus, and then at risk for esophageal cancer to arise. So the main risk is having the esophagitis. So if you've had symptoms of reflux and a family history, it might be worth getting checked out. Although it's not very common in women. So Barrett's is more common in men, and other factors that affect Barrett's are high BMI, white ethnicity, smoking. So if you have definitely had long-standing reflux, it could be worth getting checked out. Yes.
Do you recommend or think that taking probiotics is good for you?
Well, it depends for what. So, I was looking at through the Costco magazine I get delivered, and there were, like, every other page was a different probiotic advertisement. There's a lot of marketing going on for that, and I think some of it's probably hype more than actual science. So, the thought of probiotics primarily is that bacteria are not all bad. Right? We need bacteria to be healthy as well, and that we take antibiotics and kill off some of the good bacteria, then the bad bacteria can cause negative effects, and that by taking probiotics, you're kind of balancing out the mix of bacteria. And there's some truth to that, but having a varied diet, eating lots of fruits and vegetables and healthy proteins and all of that also helps. So I'm not sure if you're already having a healthy diet, I'm not sure how much better you're going to get with probiotics, although some people feel that taking it with antibiotics, well, if you're on a week of antibiotics, taking a probiotic may help as well, prevent complications from the antibiotics, and that may be true too. But just take it to be healthy, like a baby aspirin a day, I'm not sure that the science is there to support that. You're welcome. Yes?
Same with yogurt? Is it recommended over taking a capsule, or is this?
Yeah, a lot of yogurts are high in probiotics, so that's a good option too.
You had a slide that had things you could do to reduce risk factors, I think folic acid. What were the things again?
Yeah, again, these are all small impacts.
Okay.
So these are probably the biggest, or potentially biggest, is fruits and vegetables, along with activity. So concentrating these things here. It's probably more. So if not doing these is going to be a bigger impact than doing any of these,
Okay.
unless there are certain conditions, genetic conditions, where there's lots of polyps, dozens and dozens of polyps, where it is helpful for aspirin or other NSAIDs to reduce the polyp burden. Then your average person with colon polyps or average risk, these are small effects compared to what you can do with these things. So,
The problems in the colon, such as colon cancer or polyps or whatever else, I'm not an expert on colon. But is it primarily only in the large intestine or the small intestine as well? Because my concern is if it only goes in so far and you have cancer in the small intestine, how do you detect that?
sure. Good question. Colon polyps are much more common than small bowel polyps. Small bowel polyps can happen, but they're very rare. There's not enough incidence to warrant doing routine screening for small bowel polyps. Sometimes, like I said, there are patients who have lots of colon polyps, hundreds sometimes, and those patients have syndromes where they can get small bowel polyps as well, and that would be a reason to do that, to look for small bowel polyps. If there were symptoms, unexplained iron deficiency anemia, even after having had a colonoscopy and endoscopy, then checking the small bowel would be something to do as well. Did I answer your questions? The way it's done can be with endoscopy. We can go down far into the small bowel with special instruments, or with a similar capsule we talked about for the colon. The original capsule was designed for the small bowel. So it's a pill with a camera and a light and a wireless receiver and a battery all inside the pill. And that pill is swallowed, and a patient wears a little computer receiver on the belt or strap for the 8 to 12 hours they're doing the study, and the pictures get set wirelessly to the receiver. And that can be downloaded afterwards to make a video to look at the small bowel. The pill passes out in the stool to be flushed to the city sewer district for retrieval. But that's called a small bowel capsule study. And if found something abnormal, that can be followed up then with an endoscopy. So check that out.
Thank you.
You're welcome. Well, yes.
Are you at an increased risk for colon cancer if you've had other cancer?
Sometimes there are some syndromes that
Like
can associate with uterine cancer, bladder cancer, kidney cancer, among others. That if you had a cancer, it's worth talking to your doctor about to see what other possibilities there could be. There are certain testing that's done. Some of the most common ones are called Lynch syndrome, and that can be tested in different ways. But sometimes if there's a strong family history of colon cancer or personal history of colon cancer, seeing a genetic counselor can be helpful to see what a screening may be worth doing. But if someone's not had their baseline colonoscopy at 50 or depending upon their family history, that's certainly worth doing anyways, given that. So the nurses in the office are very familiar with all the different bowel preps, and the nurses at endoscopy are very talented and experienced and caring. So if anybody does have needs for questions or for procedures, I would highly recommend getting in touch with the office or and coming to see the ACMC nurses. Here they're very good.